Hello and welcome to this event with the Chartered Institute of Ergonomics and Human Factors. My name is Sam Cook and we are hosting this event today with the Israeli Human Factors and Ergonomics Association, and I would like to welcome Joan to introduce herself.
Hello to all, or ברוכים הבאים לכולם. I'm Joan Geiger, or for those who know me in Hebrew, I'm Joanna. I'm the chairperson of the Israeli Human Factors and Ergonomics Association, and I'm very pleased to be opening this series of joint webinars between the CIHF and the Israeli Association on a subject which is close to all of us, ergonomics in healthcare. I think it's one of the areas in which our ergonomic output is most critical and most beneficial. I'm very much looking forward to hearing from our speakers and to all of the speakers and to the discussion afterwards. And I want to thank, first of all, the speakers for their willingness to share their knowledge and their experience with all of us. I also want to thank Ila Gold of the IHFEA for her help in coordinating and planning. And a huge thanks to all the members of the CIHF, Iris, Tina, and Sam Cook, as well as Fran, for their assistance in organizing, technologizing, and supporting the entire platform throughout our numerous emails, meetings, Zooms, etc. And of course, thanks to all who are attending. I truly believe that this kind of collaborative sharing is really what advances ergonomics knowledge and practice throughout the world. And I look forward to the rest of this series and to many more collaborative projects in the future. So thanks to all. And back to Fran, who will introduce the speakers.
Thank you, Joan. So just a few bits of housekeeping before I pass on to our chair for today. So our presenters for Ergonomics in Emergency Response will be Dr. Rami Sagi, Mike Henson, and Dr. Yuval Bitan. And our chair, as I just mentioned, is Fran Ives, who will introduce our presenters in a bit more detail. I have a couple of points to mention first of all. So you can ask questions in the chat function, which is at the bottom right-hand side of your screen. Please preface your questions with a Q:, so we can identify these clearly from the other general chat. Please also bear in mind that there are people with different levels of experience on the webinar session today, so please try to keep it jargon-free and to the point, and make sure that you're as inclusive as possible in a public forum such as this. Regular delegates will know that occasionally there can be problems with the platform system. So if you are having any difficulties, please check your web browser first of all, as we know that Microsoft Edge can cause some problems with this platform, and try using a different platform. Please also note that a recording will be sent out of the webinar for today. So if you are unable to experience it, then you will be able to access the recording at a later date. If there is a bigger broadcast issue, which will affect myself as well, then please keep an eye on the chat as we try to resolve any issues in the background and get us back up and running. I'll now hand over to our chair for today, Fran Ives. Thank you.
Thanks very much, Sam. So welcome everybody. As Sam has said, my name is Fran Ives. I'm a Chartered Human Factors Specialist working within healthcare in the Midlands. And it's with great pleasure that I introduce our first speaker for today, Rami Sagi. So Rami is a paediatrician and he's got master's degrees in health administration and in political science. He's been an adjunct lecturer at the Department of Military Medicine at the Hebrew University in Jerusalem since 2013. Rami has served nearly 23 years in the Medical Corps Israel Defence Forces in a variety of field duties, including as a medical officer of combat battalion, a regional brigade and a division. During 2012 to 15, he served as the head of the Southern Medical Command, and his last role was the Deputy Surgeon General and retired as a colonel. From 2018 to 2020, he was the Deputy Director of the Ramin Medical Center, one of the leading medical centers in Israel. Since then, he's been the Director of the Medical Services Division at the Ministry of Health and is responsible for promoting medical services in centers all over Israel. So, Rami, welcome, and over to you.
Hello, everyone. Well, in the last 2.5 years, I'm the head of the medical division in the directorate which operate and coordinate all aspects relating to management of the government and medical centers. And we have 11 general centers, 4 geriatrics, and 9 mental health medical centers. I was the head of the Israeli field hospital to Ukraine, the second round. I am very proud to be here and to share my experience with you. Well, the State of Israel has an experience based upon more than 65 years of taking part in many humanitarian missions all over the world. All those missions, except to Ukraine, were held by the IDF, the Israel Defense Forces Medical Corps, which operates a resourceful and trained field hospital with an integral logistic component. The challenges of operating field hospital in humanitarian missions include unexpected medical diagnosis, complex ethical dilemmas, and issues of collaboration and international coordination. Although the Israel Defense Force Medical Corps has an established protocol to operate the field hospital, it is of great importance to fit the type of medical service to the exact needs of the scenario. In January 2010, I was the head of the pediatric division in the Israeli field hospital in Haiti due to a huge earthquake, 7.2 on Richter scale, which was responsible for a lot of damage. 300,000 people were dead, another 300,000 people were injured, and nearly 1 million people became homeless. In this slide, you can impress from an earthquake-oriented hospital with advanced capabilities, a variety of specialties, and its main goal to limit the number of potentially treatable victims. The hospital was built on a soccer stadium in a close proximity to the affected area, allowing high accessibility for the patients to come or to be evacuated. The choice to bring this kind of hospital, what we called a sophisticated hospital with advanced capabilities, was due to our experience with disasters and earthquakes and the fact that the local hospitals often destroyed. And as you can see here in the slide, you can see the flows from the entrance through the triage and then whatever, to internal medicine, to the intensive care unit, maybe to recovery, orthopedics, whatever. But you can see the flow from the entrance to the field hospital. Well, on November 8, 2013, Typhoon Yolanda made landfall in the Philippines. Yolanda tropical cyclone was one of the strongest storms ever recorded, and the damage it inflicted was extensive. About 9,000 people were killed, making it the deadliest storm in the Philippines in over 130 years. It is estimated that more than 28,000 people were injured and over 4 million were displaced from their homes. Well, for the Yolanda response, we realized that we need a totally different model and prepare to provide medical services that would address the overall medical needs of the local population. And that would do so by integrating into existing medical infrastructure. We opened the general hospital integrated type using a facility with triage and ambulatory medicine located in tents outside of the structure and address the needs of the majority of the patients. Inside a permanent structure were the operating room, imaging department, laboratory, and obstetric and gynecology services, as well as inpatient wards. During a 10-day mission, a considerable number of patients were treated. Much of the medical care was devoted to treating local residents who were not able to receive basic medical treatment even before the storm, due to the limited baseline resources available routinely in this region. Okay, so on February 24, 2022, hostilities broke out in Ukraine, resulting in humanitarian crisis with a lot of injured civilians, many people that were displaced, and a lot of refugees fleeing the country. The crisis led to a severe disruption of routine medical services. These circumstances, combining warfare and refugees, pose major challenges to the international aid community. treating the wounded, addressing the medical and the psychological needs of the displaced populations, meeting routine medical needs of underserved local populations, and strengthening resilience through capacity building of the disrupted local healthcare system. The State of Israel, for the first time, to deploy a civilian field hospital. To the best of our knowledge, it was the only state-level foreign field hospital deployed in Ukraine. Well, this unique mission requires addressing immediate challenges in the pre-deployment phase, understanding the exact medical needs, defining essential logistics and security requirements, coordinating with the local authorities, and designing the field hospital accordingly. Well, a rapid assessment team was sent and worked in close collaboration with the Israeli Ministry of Foreign Affairs team on the ground and with the Ukrainian health and local authorities. We became aware that inside Ukraine, although the war casualties were being treated in Ukrainian military hospitals in the combat zones, there was severe disruption of routine medical services, leaving the local population as well as the refugees deprived of basic medical care. We had a dilemma trying to define the optimal site for the field hospital. While it was evident that the main medical needs were inside Ukraine, we had to consider the security risk of operating in a country at war. Although the main battlegrounds were in the east of the country, we were aware of sporadic missile firing in our planned deployment area. This necessitated taking specific security measures, and we therefore planned our deployment accordingly. The field hospital was located in a town named Motsiska on the main refugee route 15 kilometers east of the Medica crossing in the area not directly affected by the combat. This enabled us easy access to the hospital while providing relatively safety for the patients and the staff. Medical personnel from the most of the Israeli health organization took part in this field hospital. We asked the directors of those organizations to recommend us for the suitable personnel to this unique mission. A great importance was to hold a few preparation days for creating a team spirit, IT practice, dealing with complexities like ethical, hard decision, exhaustion, and frustration of personnel, and to coordinate expectations about the scenario and the need for flexibility and versatility. In this slide, you can see 6 of my personnel, which didn't know each other before this mission. And in my role, in my duty, I had personnel from 27 organizations around Israel, and you want them to work in a good manner. And look at this slide; you can see them. They are looking like a team, and this is what you want, to make him a team in a very short time. Well, the hospital was established in a school complex, you can see it in the left side of the slide, with a tented facility housing outpatient activities. Hospitalization wards, pharmacy, laboratory, and staff accommodation were housed in converted classrooms inside the school building, providing increased protection as well as cellar serving as an air raid shelter during the daily siren alerts. Functional units of the hospital include triage, emergency department, outpatient clinic, pediatrics, obstetric and gynecology, surgery and orthopedics, a mental health team and auxiliary services including imaging, laboratory, pharmacy, and medical logistics, as well as advanced information technology and medical record system. The hospital was completely digitalized. In these 2 slides, you can see how the flow was inside the outpatient clinic. You can see a nurse registrated one in the left side, registered one of the patients, and then he goes to the physician in the right side. This is a geriatric physician, which check him and also print all the data in the computer. This is how it looks inside the outpatient clinics from far away, but you can see here the nurses also taking blood test. You can see that there is a division between where the patient is registered and where he's checked with the curtains. And also due to the fact that it was at winter time and it is very cold, every tent is getting a warm facility inside it. Well, we work in 6 main efforts medical treatment also using advanced technologies, including an innovating telemedicine unit, what we call Shiba Beyond. We brought a special team for training healthcare professionals, resulting in nearly 800 Ukrainian medical personnel receiving training in a wide range of medical and psychological aspects. In order to maximize access to advanced consultations, we implemented large-scale telemedicine technologies, as you can see in this slide, and more than 100 patients got consultations with the most experienced specialists in Israel utilizing telemedicine technologies. We established a collaboration system with the local leadership for referral, evacuation, An important component of humanitarian missions is increasing the impact in the post-deployment phase by continuing local capacity building. It included bringing dedicated staff and mannequins from the Israeli National Center for Medical Stimulation and delivering structured training courses. In addition, clinical training was provided in the clinics, wards, and joint surgical activities, as well as in telemedicine techniques. And if we're talking about joint surgical activities, we established a collaboration system with the local leadership for referral, evacuation, and coordination of surgical activity to carry out the adjacent local hospital by mixed surgical teams. And in this slide, you can see how the operating theater is being in a local hospital. And you can see that the equipment is not new. And look at the bed and look at the left side. And here you can see how we work together. You can see some of the Israeli physician. I think this is the gynecologist surgeons. And also on the left side, there's a general surgeon. And you can see that they're working together with an Ukrainian nurse. So working together, operating together, it's something which is very, very important. I think it's something which is very exciting. Well, by its very nature, an Israeli field hospital in Ukraine attracts a lot of attention. Media from all over the globe covered the hospital activities. We made a lot of virtual tours, as you can see the right side, in the hospital for communities all over the world. We had the honor to host some very important people, including the Israeli Minister of Health. And as you can see in the middle of this picture, holding a microphone, this is the Israeli Minister of Aliyah and Immigrant Absorption. Her name is Pnina Tamanu-Shata, and they came to Ukraine to visit us and to see us from close. The last effort is internal and was aimed to our personnel. We act in many creative ways. We organize a lot of activities, including daily live performances of famous Israeli artists through Zoom. And as you can see here, this is Ninette. She is a very famous Israeli artist. So we heard her, and you see everyone was listening to her by Zoom. You know, it's not like a live concert in the O2 Arena in London, but I think it has also an impact. We have also sport activities like sunrise yoga, as you can see in the right side, and special meals serving local food, the welcoming of Shabbat, what we call in Hebrew Kabbalat Shabbat, a telephone call from the Israeli president for blessing us, and much more. We found this effort crucial to keep high staff motivation and to encourage the resilience. Well, here you can see the hospital activity, which was operational for 6 weeks. During this period, 6161 patients were treated, nearly 1,000 children. The condition treated ranged from chronic non-communicable diseases such as hypertension, diabetes, and osteoarthritis to acute and emergency conditions, including infections like acute appendicitis and fractures. 65 patients were hospitalized and 59 patients underwent surgery. 7 patients were brought to Israel. We took them to Israel for advanced care, which was unavailable in the field hospital or in local health facilities. The hospital was closed after 6 weeks of operation as there was decline in the refugee flow, and it was felt that the acute phase needs had been addressed, as well as for budgetary reasons. However, we maintained contact with local medical facilities for continued support and capacity building. We put a special attention on an excellent patient experience. We distribute blankets to the patients to get warm from the freezing weather. We activate logistics staff for distributing a hot soup or a hot tea to warm the patients. We gave toys and panda dolls for children, panda bears, to children waiting for the treatment in our facility, and we use a lot of other means for that purpose. Well, I think in this slide you can see the patient's satisfaction for the treatment that she got. She's kissing the bald head of Dr. Ido Promkin, which was the head of the outpatient clinic, and I like this picture very much, this slide very much, because you don't see it every day, not in Israel, but it's, I think, something very emotional and very nice. Well, for summary, several important lessons were learned during our deployment. Contrary to our initial expectation, despite the operation being in a war zone, the main necessity encountered was delivery of primary care to both the refugee and local population due to the compromised medical system. Capabilities were enhanced accordingly, shifting the emphasis from surgery of war wounds to ambulatory routine medicine, increasing the number of primary care physicians in the team, and task shifting to areas of increased patient load. We believe that this capacity building effort should not be limited to the period of deployment, but rather use the acute phase deployment as an opportunity to establish a dialogue with the local healthcare community for continued collaboration and support. Beside the field hospital activity of treating patients and training medical staff, we believe that not everything that counts can be counted. Throughout the mission, we felt a sense of trust and gratitude from all those we encountered, patients, medical staff, and administrators. Once again, we learned that dispatching a team delivering medical care and extending a helping hand in the time of need, especially when done by a national entity, contributes greatly to building the people's faith, hope, and resilience during the crisis, and had a critical role in the recovery effort. The dilemma of dispatching a civilian team to a war zone and investing resources in this handover will always exist. However, we feel that providing hope to a nation in need is part of our duty as humanitarians and healthcare providers, and we hope that the international health community will devote the necessary resources to this important cause. Thank you very much.
Thank you, Rami, for that excellent presentation, and what a way to start as well. I just wanted to pull out a couple of questions from the chat, if I can pose them to you, Rami. So we had a question which was around patient safety. So how do you manage patient and staff safety in such conditions? And is this something that you proactively do and think about in your planning?
Yeah, we had very tough security requirements. And again, in the school building, in the school structure, we had a shelter. And I think we had days that we have more than 3 or 4 times in all the hours of the day, even in the night, that we heard the sirens. And we went to these shelters. And, you know, it's the best thing that you can do, both for the patients and both for the staff. And, you know, this is something which is, I think, maybe typical for us as an Israelis. You know, we heard the sirens. I mean, all the personnel, we went down to the shelter. We waited there for about 15 minutes. And then we got back and work regularly as nothing has happened. And we do it several times a day. So, I mean, I think this is a part of the security requirements, but we have really tough security requirements beside of this. But this is for the safety of the patient and also for the personnel.
And can I just also ask, in terms of thinking about patient safety of the procedures and maintaining that high level, which I'm sure you're all inspiring to, is that something that you actively think about and strive to achieve?
Yeah. So as you can see, all the surgical and all the surgical things, we didn't make them in this hospital. I mean, there was a local hospital where all our surgeons work together. Why we've done it there? Because of safety. I mean, we thought that if there will be a sequela. So it's better that it can do in a hospital that we can treat it. And we didn't do, I mean, you need to think wisely what kind of surgeries you are doing. I mean, we didn't do any surgery that we can do because of safety of patients. So we choose wisely the kind of surgeries that we've done, and we didn't do it in the hospital that I show in the slides, but we've done it in the local hospital, which was nearby when our surgical teams work together. And the same for labors. Also labors, we did the labors together in the local hospital, not in the school and the tent facility.
Great, thank you, Rami. It's been a great start to this session, and we'll invite you back at the end to answer some further panel questions. So thank you.
Thank you.
So I'd next like to introduce our second speaker, Mike Henson, who will be talking to us about search and rescue. So Mike spent 16 years in the Royal Navy as aircrew, and he has operated in some of the harshest environments on Earth. And during this time, he conducted anti-piracy operations, anti-submarine operations, delivered humanitarian aid, and conducted search and rescue, for which he has received multiple honours and awards. Since leaving the military, he served as a helicopter paramedic, winchman for Bristow Helicopters, and is an advanced search and rescue paramedic. As if that wasn't enough, Mike is also an MSc in human factors, and his interests lie within aviation, rescue and pre-hospital care sectors. So Mike, thank you very much for joining us today, and over to you.
Hello. Thanks very much, firstly, Rami, for that interesting chat. And also thanks to the Chartered Institute of Human Factors and Ergonomics for inviting me back to talk about this this interesting subject. Cool. Okay. I just want you to imagine for a moment needing the search and rescue helicopter service. So the search and rescue helicopter service would attend to you if you were having the worst possible day of your life, probably in the worst possible location. And I'm assuming when I think about, hopefully I'll never need the search and rescue helicopter service, but if I was a service user, what I would want is that service to be the safest, the best performing, the most efficient, reliable, and proficient service that could possibly be. So my name's Mike Henson. I'm now the clinical manager for Bristow Helicopters, who provide the UK Search and Rescue Helicopter Service, and I spend a lot of my time trying to make the service as high performing as possible. I'm not on social media, but if you do want to contact me, I've left my email address up there, and I'm more than happy to take emails. So in the very short time that I have, what I'd like to do is kind of have 3 points, really, the 3 intended outcomes. The first one, I want to just introduce the Search and Rescue Helicopter Service. The second, I want to show a quick win, how ergonomics and human factors are definitely enhancing our service and improving the service that we deliver. And then my final point is, or final outcome, is just to highlight one of the greatest ergonomic challenges in emergency response, certainly in the UK, and it's what I believe is the thing we should all be focusing on. So the Search and Rescue Helicopter Service is, sorry, what is search and rescue, first of all? Search and rescue is an activity that's normally coordinated by a rescue coordination authority, where available personnel and resources are used to locate persons in distress, potential distress, or missing, and return them to a place of safety whilst catering for their initial medical needs and other needs as necessary. And how the search and rescue helicopter service does this is around the UK we have 10 search and rescue bases that's soon to be increased to 12. I say soon, in the next few years. They operate 24 hours a day, 7 days a week. Each base has 2 pilots, one winch operator, who is the gifted guy who places the winch paramedic down and manages to get him onto moving vessels or the bottom of huge cliffs via the winch. And then you've got the winch paramedic who actually goes down on the wire to assist and attend to casualties that in otherwise inaccessible areas. Each base is also has 2 engineers as well, which that maintain the aircraft and ensure that there's an aircraft serviceable ready to go. And we are coordinated by the Joint Rescue Coordination Centre Air Rescue, and that's in the south of the country in a place called Fareham. And of course, there's more to the search and rescue system than actually search and rescue helicopters. It's an amalgam of separate government departments, and it does incorporate emergency services, volunteer organisations such as the RNLI, the Coast Guard, the Ground Coast Guard Agency, the Mountain Rescue, the police, the fire, the ambulance service. So it's a huge system, and it's a system of systems, if you like. But my kind of main focus is on the search and rescue helicopter service. So I don't know if there's anybody out there who was at my last talk, but during my last talk, I presented a problem that I was experiencing within search and rescue. And the problem is that the Resource Council UK state that for every minute effective cardiopulmonary resuscitation is not taking place, when somebody's in cardiac arrest, there's a 10% chance more likely that the patient will not survive. So for every minute that CPR is not ongoing, there's a 10% chance more likely that the patient will not survive. Now, with the best will in the world, when you're getting somebody out of an inaccessible area to the helicopter or to a place of safety, it's very, very difficult to do that, as well as provide something like cardiopulmonary resuscitation. So the problem I presented last time I was here was, how do we continue CPR whilst winching a person into the aircraft? So, and to just give a bit of a flavour of the challenge I'm talking about, this is a typical place where we would find a injured or ill person, kind of remote location, either bottom of a cliff. They're either ill with a medical issue, or they've had a fall and they're experiencing some trauma, and we often have to recover people from this area to the aircraft. And when we're trying to do that in the safest possible manner, there's also an efficiency trade-off. So therefore, getting somebody from that area into the aircraft is going to take time. And when a person needs cardiopulmonary resuscitation, it presents a huge challenge for us, because if we take 2 minutes, they're 20% chance more likely to die. It's going to be more like 5 minutes. So therefore, it's 50%. So that was the problem I presented. We've been working on solving that problem using human factors and ergonomics tools, and I think we've about solved the problem. So if you can just play the video for me, please, Sam. So what we did, we decided to introduce a mechanical CPR device. Now, of course, we didn't have much to do with the design of this product, but what we have done is used human factors and ergonomics tools to ensure that the product will fit into our system and provide what we need to provide. So as you can see, it's fairly small, fairly light, and it can provide exactly what we're looking for. That's great, Sam. Thanks. Okay, so we believe we've kind of solved that problem. We can now, with this mechanical CPR device, we can continue cardiopulmonary resuscitation whilst winching to the aircraft. And just some of the human factors and ergonomics tools that were used in order to bring that piece of equipment into service. So we first of all conducted hierarchical task analysis to fully understand the task in hand, and that was done by retrospective reviews of patient clinical records, but it was also done by an appreciation of the scope of practice that our paramedics would be working to. We conducted failure mode and effect analysis, usability testing, both UI and UX, REBA, and we also conducted ground trials, airborne trials, and observational trials. And I'm pleased to say at the moment that mechanical CPR is being rolled out across the whole country. So a bit of a success story, I hope, for how IHFEA is impacting our service. What I'd like to highlight now is, for my third outcome, is what I see as the biggest human factors and ergonomics challenge that's facing certainly search and rescue helicopters, but also I would suggest it's all emergency response in the UK. And I've noticed since completing this presentation that it seems to be highlighted on the news every day. So I don't know if it's just me noticing it more, but it's certainly been ongoing for quite some time. And how I'm going to tell you about this challenge is I'm going to tell you a story, but it's actually going to be three stories. Because of patient confidentiality, I've changed the names of the characters in my stories, and I've also changed the dates and times when it occurs. And what I want to kind of get across is that it's not a one-off story. This is happening all the time. So it might be a shock for anybody who kind of works in emergency response. They'll be completely unsurprised. It is based on a true sequence of events, and it's happening today. It's happening nationwide. So my first story is, I want you to meet Maggie, and of course that's a picture of Margaret Thatcher, and it's not the real Maggie, and Maggie was not her name, but Maggie is an 81-year-old female. She was admitted to hospital by paramedics, and she had a fall at home. Whilst being assessed by the paramedics, Maggie told them that she was struggling with activities for daily living, so struggling to cook, clean, struggling to do basic hygiene. So she was feeling like everything was just a little bit difficult. She really likes her neighbours, and she's got a good support network with her neighbours, and she likes living in her own home. She's a very independent woman. Her daughter lives, approximately 200 miles away due to work commitments, and Maggie refuses to move in with her daughter because she doesn't want to move from her geographical location, and equally she's an independent woman. Maggie requires a social care package to support her to live independently in her own home. She's stuck in hospital, and the only thing stopping Maggie from going home is the implementation of a social care package. So Maggie is currently stuck in a ward, wanting to go home, but she can't because there's no social care available in order to look after Maggie and allow her to live an independent life. My second story is Brenda. I want you to meet Brenda. So Brenda is a 70-year-old female, and in fact, today is Brenda's 70th birthday. She lives alone after her husband died 2 years ago. She's a very active woman who lives life to the full. She recently returned to the UK after visiting her son and grandchildren in Australia. Although she lives in Manchester in the UK, she's visiting a daughter who lives on a remote Scottish island. Brenda doesn't know this yet, but in about half an hour, so in about 30 minutes, whilst having a birthday meal on a remote Scottish island with her family, she's going to suffer a CVE, which is, I think, it's a cerebral vascular event known as a stroke. It's probably more commonly referred to. So a clot that is either the result of her recent long-haul flights or her undiagnosed atrial fibrillation, which is a heart condition, will occlude a vessel in her brain. To have any chance of returning to normal life, she will need to be in a stroke centre and receive clot-busting medication within 4.5 hours of the onset of the stroke. But because Brenda is on a remote island with her daughter, a search and rescue helicopter will attend her on the island. And because the helicopter can't land at the mainland hospital, so the stroke centre, an ambulance will be requested to transport Brenda from the airport to the hospital. And all this has to be done within this 4.5 hour window. So, just a bit of a side story, but the ambulance that will eventually pick Brenda up from the airport off the search and rescue helicopter and transport her to the hospital for the clot-busting treatment is stuck in a 4-hour queue because the emergency department is full and there's no beds available at the hospital. Patient flow throughout the whole hospital has stopped, and Brenda will not receive her treatment in time. And because of that, she will never return to her old life. She will never be as active. Story number 3, meet Jimmy. Jimmy is a 16-year-old male. He loves music and playing guitar. He recently split up with his girlfriend. Her new boyfriend and his mates have been bullying Jimmy on social media and whilst he's been attending college. Jimmy is feeling low, and tonight he will consider jumping off a bridge in an attempt to take his own life. Whilst looking over the bridge into the water, Jimmy will think about his friends and family. He decides to go home and tell his parents everything that's going on in an attempt to stop the bullying and move on with his life. Unfortunately, whilst climbing back over the barrier of the bridge, Jimmy slips and falls into the water. The search and rescue helicopter that will eventually go and pick up Jimmy is still waiting to hand over Brenda, who's suffering a stroke, who requires handing off to the ambulance in order to go into the hospital that Maggie, unfortunately, is taking up a bed because there's no social care packages in place to ensure that flow through the hospital goes. So what is a problem with social care is actually manifesting itself with a search and rescue helicopter unable to attend a search and rescue job. I believe the answer to these problems and this problem that is happening right now will come from the science of human factors and ergonomics. And I want to just push out a call to action to all the human factors and ergonomists out there to have a little look at this and think about what we're going to do, because our life depends on it. Maggie's life, Jimmy's life, and Brenda's life all depends on it. Thanks very much for listening, and I'm happy to take any questions.
Brilliant. Thank you, Mike. It's a good job you are willing to take questions, because we have quite a few of them coming through. I'm just going to pick out one or two now, and I'll save the rest for when we come to the end of all of the sessions. So one question I wanted to ask was, how much time does it take for strapping the CPR machine to patients, and does that create any challenges in emergency situations?
Yeah, it's a really good point. So the evidence around mechanical CPR is actually it's pretty limited, and there's nothing to say that mechanical CPR provides any benefit over and above what manual CPR would be. However, that's because the trials and the evidence that came out of that, it was all conducted when there was lots of resources. So, lots of nurses, lots of paramedics on scene. So people could change. They could change every 2 minutes and carry on the CPR. When you're in resource limited situations or when you need to travel, that's when mechanical CPR really comes in. And we work. We work tirelessly with simulation to ensure that we can conduct manual CPR and apply this kit. Now, I know in the video, the guy was just applying the kit to what looked like a light dummy very quickly. But what we would do is we would do it in stages. So we would maybe only take 10 seconds off the chest in order to get the back plate in. We would then conduct another round of manual CPR. Then we would take no longer than 10 seconds to put the device actually on. Then we would then get it going. So although in the video it was one move, it tends to be done in stages to limit that time off the chest. Once that's in place, obviously it's a proficient piece of kit.
Great, thanks, Mike. And last question for now is, have you used the mechanical CPR in a water rescue scenario? And if so, is there any risk of shorting or the users getting shocks?
Say again?
So if you have used the mechanical CPR in a water scenario, is there any risk of it shorting or the users getting a shock because of the water?
Yeah, so there is, I think whoever's asked that question knows a lot of the limitations of the devices. We actually, we've gone for a lightweight, really, when we were trialing it, we actually put it through its testing, and we actually trialed 3 or 4 devices. One of the devices were excluded from our organization because of where the air intakes and electrics were positioned on the device. We did have problems with water ingress. Equally, we've had that couldn't be winched. So we've kind of gone for the small chiller version, and that's because it performed best in test. It's not, the panacea. It's not the golden bullet or the silver bullet, but it is the best what's out there.
Brilliant, and thank you again, Mike. You'll be able to see the chat shortly. I think it's safe to say people very much enjoyed some of the stories, but also the application of human factors and ergonomics to some really knotty problems and real life-saving problems. So thank you very much. We'll see you again at the end.
Brilliant. Thanks.
Thank you. So now on to our final speaker and final presentation of the day. I'd like to welcome Yuval Bitan to the session. So Yuval is a human factors engineer and a research scientist studying cognitive systems engineering at Ben-Gurion University of the Negev. His research is focused on the cognitive strategies that human operators apply to handle incomplete and conflicting interaction with information and their impact on decision making. Implementing the knowledge acquired in this research into the design of systems and processes throughout the healthcare system to make them easier and more efficient to operate and improve patient safety. Dr. Bitan was an assistant professor at the Department of Medical and Industrial Engineering at the University of Toronto. a research associate at the Cognitive Technologies Laboratory at the University of Chicago, and at Human Era in the University Health Network, Toronto, Canada. He holds a PhD in Human Factors Engineering at the Ben-Gurion University of the Negev in Israel, where he is a faculty member of the Department of Health Policy and Management and serves as the director of SIMREC, the Research Centre for Simulation in Healthcare. So I'd very much like to welcome Yuval and look forward to the final presentation of this session.
Thank you, Fern, and good evening, everyone. Thanks for joining us. It's so nice to see people actually from all around the world here. It's really nice. I went through the chat list, people from Nigeria, India, Malaysia, Norway, Canada, and of course the UK and Israel. So thanks everyone for joining us. Today I will talk in my short presentation about a study that we did while I was working at the University of Toronto in Canada, working to design and evaluate a new paramedic bags. I'll try to show you what was the approach that we used and how we tried to implement science into the design of these new bags. So I'll talk a little bit about the paramedics' work environment, about the design process, and then if I have time, I'll talk a little bit more about the usability study and some of the findings from the studies that we did. Quick acknowledgement, the study was sponsored mainly by the Nature and Science and Engineering Research Council of Canada, together with the FireTech and Northumberland County EMS, and part of it was presented in a paper that we published at Applied Ergonomics a couple of years ago. So when we start to think about human factors and how to implement human factors in healthcare, our main idea is to try and better understand how humans behave, how operators behave, how they make decisions. In the idea that if we will understand better how they work, it will be easier for us to design the systems and the work environments that they are using to be more compatible for them, which will make their work easier and, of course, safer. And one of the main models that we try to use when we work with emergency operators, we look at Kahneman's System 1 and System 2 model. I'll not go into too much details. It's all in this very interesting book and papers that Daniel Kahneman published. But the main idea of System 1 is that is a behavior that we act fast and automatic and in spontaneous way, compared to the System 2 approach, where we more plan ahead what we are going to do and require more dedicated cognitive resources. Now, of course, when we talk about emergency situations, and we just heard a little bit from Mike about his experience, and we can all understand how stressful these situations are. They have a big impact on the people that operate. Even experienced paramedics will feel the pressure, and it's a very unique condition where people find it very difficult to plan ahead, and usually they act and respond automatically to the things that they need to do. And this is why we are trying to, when we design things, when we design equipment for people that work in these work environments, we try to design them thinking about System 1. So how operators in this suboptimal work environment can use strategies that will help them work and achieve their goals, even that they are working now under these System 1 very stressful work condition. Another thing that we need to think about is that healthcare is a very complex work environment. We saw it also in Rami's presentation. It's a system of systems. It's a system that is very complicated. And as Richard Cook used to say, the enemy of safety is complexity. So when we try to think about safety in healthcare, we definitely need to think about how to make things simple. And the two things that we are trying to achieve when we design equipment for these kind of work environments is trying to keep them as simple as possible and as resilient as possible. And we actually took all these ideas when we started to work on this project in Ontario in Canada. And our goal was to apply a user-centered design approach to the design of new paramedics response bags. And what you see here in the picture to the left is something that I got from Professor Yuval Bitan. It's just a picture of an emergency response bag from the 40s. So basically, this is what they were using, and you'll see in a little while that still many EMS services still using similar equipment. But before we get into this, I just want to talk a little bit about the paramedics work environment. As you can imagine, it's a very unique work environment. They have to use a lot of equipment, but in a very effective and efficient way. By the way, I'll show you some pictures during this presentation. All the pictures are from drills. These are not real patients. There is no real blood here. These are just actors. So the EMS services, emergency medical services, is a complex system, and it demands both a high level of technical competence and the ability to make and carry out decisions very rapidly. And when we try to design equipment for these workers, we must keep this in mind when we try to design equipment that will be easier for them to use. So they're working in extreme situations, very high workload. One of the unique things is that they can never know exactly when they're going to use their equipment and where they're going to use it. So the work environment is very dynamic and change a lot. And they work usually in very small groups and follow very strict protocols. Here to the left, you can see an example of a bag, how current bags for the EMS in most of the services in the world look like. It looks for human factors engineers. I'm sure everyone feels a little bit uncomfortable when looking at this kind of bag. And also to the right, you can see many of the bags that are carried on one shoulder, which is, of course, not very healthy and not very safe. So when we started this project, the one very unique thing that we did was to start and work with a group of paramedics in the service by working with them or teaching them basically some of the basics of human factors. So we worked with this group of paramedics for 2 days on a very short workshop to teach them the basic of human factors. And then together with them, we started to work on redesigning the bags that they were using. You can see here in the picture, the 3 paramedics are really measuring each of the items that they have in the bag, and they have quite a lot of equipment in these bags. They started to measure them and really consider each of the pieces of equipment, if they need them, how many parts they need, how many pieces they need, and where exactly would be the best way to locate them. Another advantage of working with the paramedics was that they later helped us first of all, in a small field studies that we did with a sample of the bags that we designed, and also they were working with the rest of the paramedics in the service to introduce them to the new bags and to teach them how to use the new bags, because they were slightly different from the current bags that they were using. And of course, like always in any project, support from the managers of the service was very important. And here in this picture, you can see the deputy chiefs and the chief of the service, part of the people that were working with us on this project. So you can see here in this picture the overall idea of the new bag. As you can see, the idea here was to organize all the equipment into kits, and each kit had a very specific purpose with a specific name. There were involved here some color coding. I don't want to get into this at the moment, but there was a lot of thinking of where exactly to locate each of the pieces of equipment. And another very important part was that they were able to carry the bag on their back. So this is a huge advantage, of course, for carrying the stuff. It's much safer. And also the main advantage for the paramedics is that they had now 2 free hands to use and operate with the patients. So the bags were smaller and lighter. Each of them had 10 or 12 cases. And the idea was that once the paramedic opened the bag, they would have direct access to the kit that they need. They can open the kit, and all the equipment that they need will be inside this kit. After we implemented the bags, we wanted to check and see and compare them basically to the old bags that the paramedics were using. And we know as engineers, it's always important to measure what the work that you did and really see if it worked and where it didn't work and what you need to improve. The challenge in this study was that the service was spread around a few hundred kilometers around, and in order to do the usability testing, we had to drive to the different stations and work with the paramedics in each of the station on some simulation. We had 2 types of simulations that we run. The simulation was conducted both inside the ambulance and in something that simulates a patient home, so we can test the equipment in different work environments. Here you can see the 2 types of bags that we were comparing. To the right is the traditional bags that they were using in this service before we implemented the new bags that you can see here to the left. What was unique about this study was that all the paramedics that participated worked in the service and used both the old bags and the new bags. And they were already using the new bags for about 9 months. So they had experience with the new bags, but they didn't forget yet the old bags. So we could run 2 scenarios, one with the old bags and one with the new bags, and compare the result and see really what were the performance. Here you can see some pictures of the paramedics going into the room. We really try to simulate the entire process of taking care of a patient from the beginning, from unloading from the ambulance, carrying the equipment to the patient's home, and then carrying them back to the ambulance. And during all this process, we try to look and see how they operate and use the equipment. To capture what they were doing, we were taking video from 3 different cameras. You can see me here carrying one of the cameras. We had 2 other cameras that looked from different directions. And after we captured all the video, we could connect or merge all the 3 angles together. You can see it here in this slide. From 3 different angles, you can see what the paramedics were doing. And then we could analyze and see how long it took them to do each task that they were asked to do, and also how accurate they were. So we could really measure exactly what they were doing. And again, we ran for each of the paramedics groups, ran 2 scenarios: one with the old bags, one with the new bags, and we could compare and see what were their performance. Overall, we had 17 teams that participated, and as I said, we were measuring both the task efficiency, and also we had a short survey that asked them about their feeling and understanding, and collected some feedback about the bags that they were using. So the main results was very promising. The main finding was that the time it took the paramedics to extract the equipment from the new bag was not longer than it was from the old bag. And this was our main concern, because we reorganized the equipment into these small kits. Basically, in order to get to the equipment, now they had to open 2 zippers in order to get into the actual equipment. But because the equipment was organized in such a logical way and was marked very clearly, it was easy for the paramedics to find the equipment, and it didn't take them longer to find the equipment, but they preferred to use the new bags. And another thing that was very important was that the paramedics started to carry the bags on their backs, instead of just carrying them on the shoulder, which again is very important and very safe for the paramedics, and also safer for the patients. These are just 2 examples from the results. Most of the paramedics thought that it is easier to find the equipment in the new bag, and that they prefer basically the new bag compared to the old bags. So our conclusion was that the new design allowed the paramedics to follow the treatment protocol, and the equipment, the way that the equipment was organized in these bags was according to the treatment protocol that they were using. So it was easier for them to follow the protocol, and also to find all the equipment that they need for each of the procedures. And as I said before, it was very important for us that the paramedics changed a little bit their behavior and started to carry the bags in a safer way. I'll end up my presentation with this famous James Reason quote: "If we can't change the human condition, but we can change the condition under which the human work." And I think that this is what all of us as human factors are trying to do all the time, trying to see how we can change the work environment in order to make it easier and safer for our customers, or our users, or our clinicians. So my take-home message for you is start studying by learning about the people that you are designing for, and what is their work environment, how they use their work environment, observation, all the basic things that we as human factors and ergonomists are doing. Design with the people. For us in this project, working with the paramedic was a huge advantage. They brought a lot of insight, and again, they were part of the process, and this is why it was also easy to implement the bags once they were ready. And last, of course, is listen to feedback and change and iterate as you get feedback that is important and can improve the products that you have. So I'll end my presentation here, and if we have time for questions, I'll be happy to answer them. Thank you.
Brilliant. Thank you so much, Yuval, for that incredibly practical example of the application of ergonomics in human factors. I'd like to ask you a couple of questions before I bring the other 2 speakers back in. Are you able to talk a little bit about the rationale and or tools that you use to decide on the equipment and the bag groupings?
Can you repeat it? I missed the end of the question.
Could you talk a little bit about the rationale or any tools that you use to decide on the equipment and the bag groupings that you selected?
Oh, okay. Yeah. The main tool were the paramedics. I mean, they were experts. They know what they are doing. We also used a little bit data. So we looked at the type of equipment that they were using in this service, how frequent they were using each pieces of equipment. But most of the knowledge came from the paramedics. And I must say that the most challenging part was to decide which pieces of equipment we are going to leave behind. So paramedics has this habit of collecting, and they want to carry a lot of equipment. And our main fight was, okay, it's enough if you have all this extra equipment in the car downstairs. You don't need to carry it on your back to the patient. So once we overcome this part, it was much easier.
Great, thank you. We have another question from someone who said that you mentioned accuracy in the evaluation of the new bags using simulations. So did you measure this? And if so, how did you measure that?
Yes, we used this video that we took from the different angles in order to see exactly what the paramedics did. So, for example, if they were supposed to bring out a specific medication or a specific syringe, and they took a different syringe and then put it back and took the right one, we measured it as, how many errors and how many correct things they did, and of course how long it took them. So we were trying to combine together the accuracy of what they did, if they did the right thing, and also how long it took them to do it.
Brilliant, thank you. I'm going to let you take a drink and take a breath for a moment, but also invite Mike and Rami back. So if you could turn your cameras and microphones back on. There have been lots of questions coming into the chat, so thank you very much for both the questions, but there's also been quite a lot of discussion and interaction as well throughout the session, which has been brilliant to see. So we've got about 10 minutes or so. I'd like to fire some questions at you that I've taken from the chat. Some of them you may well have seen. So Rami, if I can come to you first of all. So one of our participants tonight is a human factors practitioner, and they're also a member of their local mountain rescue team. And they say that mountain rescue teams, by their very nature of the environments in which they're operating in, must be really careful in deploying the right resources to the casualty. So are there any constraints on resources in field hospitals, and how do you decide what to take with you and what to leave behind?
Well, thank you for the question. First of all, as I show with my examples, one field hospital is not the same as the other field hospital. There is a protocol, but we fit it to the right scenario. And this is the reason why we send very, very early. I mean, in Haiti, for instance, the dispatching team dispatched, I think, after 2 days or 1 day after the earthquake. I mean, even before there was a official decision that we will go there, but you must assess the special needs, and therefore you do all what you need in order to plan for the scenario. So in Ukraine, the place that we were there, and again, it's under war. There is a lot of security problems. There are missiles, and we must think about the safety of the personnel, and of course also of the patients. So we knew that we are going to a place that the most of the treatment will be on ambulatory and the regular medical, and not for wounds and not for injured, because they were treated in another place in Ukraine, in the west, in the east side. So regarding the thing that we bring, this is how we do it. And I think before we had a question about the safety measures for the surgery. So I think I answered that before. I mean, we done things very, very safely and with a lot of thought if we need to do it or not, because again, it's not an injury, it's not wound, it's not life-saving. It's a medical regular treatment of day-to-day, which they are deprived of due to the situation.
Thanks very much, Rami. Mike, if I can turn to you. So what did you use to test actually applying the CPR device and use during winching? And when testing a process and designing a carry sheet for extrication, the participant here said that they struggled to find a compressible mannequin or any sort of mannequin where the weight distribution and skin friction, etc., was representative of a real world patient. So did you come across any difficulties when you're trying to test a device in a winching scenario?
Yeah, so it's a really great question, actually. We were using mannequins throughout the whole process, especially for the winching part, due to safety reasons. But we have been gifted with a few cases. Actually, we've been faced with other services, mechanical CPRs that have been on real life people, and we've taken it on risk and utilized and winched that to the aircraft. So on one hand, we were using a mannequin for the trials, but actually we do have a few case studies where we have used the equipment on in real life tasking.
Great, thank you. Yuval, a nice comment more than a question, but something that I wanted to just draw your attention to, because I think it really nicely demonstrates the transfer of knowledge and approaches. We have one participant who said that they'd used a similar approach to you, having a similar situation with highway agency patrol cars and helping them to decide on how to organise their emergency equipment. So cars, but not bags, but actually they followed a very similar approach. Just wondered whether you also had experience of using that same approach in some other scenarios.
Yes, I think that basically this is the basic of human factors. This is what we are trying to do. I think that I have experience. We worked a little bit with flight paramedics here in Israel, designing a special bag for them, and not surprisingly, it is slightly different from the one that we have for the ground paramedics. So again, working with them on their need, very specific needs, slightly different from the type of work that Mike is doing, because the flight paramedics here in Israel are doing work that is slightly different from search and rescue. So you can customize and exactly what type of equipment they need, and it really depends on when they get to the patient. So again, you can really customize the solution. And as we know, one size doesn't fit all in human factors. So we always need to keep it in mind.
It certainly doesn't. Thank you, Yuval. Rami, can I come back to you? One of the things you noted in your presentation was that you were creating teams of people who hadn't worked together before, and you showed us a picture of a group of people that didn't know each other. So how were you able to form a well-functioning and a high-performing team in such a short space of time?
Well, this was a huge challenge. I mean, when you decide that you are doing it as civilian and not from only one hospital or one HMO, health maintenance organization, and you want everyone to share, so this became a huge challenge. And, we didn't have time to interview every participant, so we asked the directors to recommend us. I mean, for the directors of that works with me, I choose them by myself. But for the medical personnel, I mean, I have at my time, at my duty, it was more than nearly 79 medical personnel. So you don't have the time for this. But what is very important, I mean, is to gather them for as much time as you can. And I have nearly 1.5 days. and give them, all the things that you want them to know, to practice, but also to talk one with each other, because you're right. They have a very short time. They need to go to a place that is, it's again, state on a war, far away from their home, and they need to work and to function the best way, because there is no reductions. I expect from them to work the best way. So you talk with them, you practice them, you talk with them again after they are coming to Ukraine, to the hospital. And this is the secret. And I'm very proud of this picture that I put, because there was one family physician from the south of Israel. There was a paramedic. There was an emergency physician from Tel Aviv. They really, really, really did know each other. And I assure you that now they are friends. They are the best friends.
That's good to hear. And obviously, knowing that there was obviously a lot of work and a lot of successful work done to actually form those teams.
Absolutely.
Mike, this question comes from somebody in healthcare, and I think those of us who are human factor specialists in healthcare know that we're very often working on our own. So this person asks, do you have anyone else in your team or within your organization that has human factors and ergonomics experience? And does that support you with the work that you're trying to do?
Sorry, I was just unmuting there. It's selling human factors is sometimes really difficult, isn't it, in organizations? What I would say is, because we, search and rescue helicopters, we have a lot of aviation specialists who it just seems to be a little bit further ahead where human factors and ergonomics is concerned. So I'm pushing on an open door quite a lot of the time. Specific human factors and ergonomics, specialists, I would say there's not many, but great understanding of human factors and ergonomics are plentiful. So it's about just recruiting the right team at the right time.
Mm. And I think that's often the way in healthcare, isn't it? Actually, having qualified human factors specialists is really quite rare, and they're often the only person. But that doesn't mean to say there aren't some brilliant people already within an organisation that might have been employed as a different speciality, but have got a real passion and an interest in human factors. Brilliant. Yuval, if I could just come to you, how easy or not did you find it to engage with the paramedic teams? You said that you did an awful lot of sort of user involvement. Was that plain sailing, or were there any challenges initially in engaging with them?
That's an excellent question, and I think it ties very nicely to what you just discussed with Mike. I think that these are all very qualified people. They are very experienced, but they are experienced in their field. So I think that we can't make them into human factors specialists, but we can give them the point of view of human factor, and I think it helps them a lot in identifying when they need to call in a human factor that will help them solve a problem. Mm-hmm. So this was what we were trying to do in this short workshops that we did for them. Not all of them were on board. I think we started with a group of, let's say, about 10 paramedics, and we ended up with 8 or 6. But these 6 were very dedicated and really invested a lot of time, first of all, with the design, and then with the implementation. So no, I don't think everyone would be on board. But if you have 1 or 2, or at least 1 or 2 ambassadors that will represent these ideas, I think it's very powerful. And also, this is what we're trying to do now in hospitals across Israel. So having kind of people that understand enough human factors to flag when they need help, and they will call in the human factors specialists that will try and solve or improve the type of work that they're doing.
Okay, brilliant. Thank you. If I can turn to Rami now, we've had a question from somebody asking, did you also have psychological support for the patients as well as your staff?
Of course. I mean, this was one of the main efforts that we have. And we found that a lot of people suffer from or need mental assistance. We were very proactive. I mean, we brought psychiatrists and psychologists and social worker, but we didn't wait that people will come to our field hospitals. We went outside for places that refugees were there. I mean, they were in schools and in other places, and we walked there and get the treatment there with some very creative methods, including talks and including some other methods. But it was one of the main effort. And, you know, my recommendation afterwards for the third role, for the third time, was to even to bring more psychiatric and more, because we saw that it was very needed. I mean, the patients, many of them, you know, all the trauma of the war have the effect. So we treat them in the mental health system.
Great, thank you. I'm going to come to my final question now. I've not been able to pull out everybody's question, unfortunately, because there's been so many. So for my final question, I'd very much like to come back to Yuval. Before reaching the final design of the bags that you showed us in your presentation, did you develop some lower fidelity prototypes? And if you did, how did you do that?
Yeah, that's an excellent question. We didn't really develop prototypes, but we tested different approaches. And at least in the beginning, we didn't have someone that would make the bags for us. So we had to improvise and take examples from different manufacturers or different things that we found around. But once we were closer into understanding what we are trying to do, we started to work very closely with the manufacturer. And then we went back and forth with him until we got into the final design. So at least with sewing bags, you know, you can't print them in a 3D printer. There are other types of equipment that I had experience with where you can just come up with an idea, press print, you have it printed, and then you can test it in the field. But unfortunately, with sewing bags, it is much more complicated, and you need to go back and forth, and it takes time. But you know, there are no shortcuts here. You must try, and at the beginning you fail, and after some time you get more success.
Brilliant. Thank you, Yuval, and thank you to all three of our speakers today. And thank you very much for the participation and the questions that we've had as well. I'm now going to hand back to Sam.
Thank you very much, Fran, and thank you for that. I'd like to say a special thank you to Fran for chairing the meeting and managing the questions for us and directing them to the appropriate people. So thank you very much for that, Fran. And also thank you very much to Rami, Yuval and Mike for their really interesting and informative presentations on this particular topic around ergonomics in emergency response. So thank you for your content on that and your time. I'd also like to say thank you to our participants today for their questions, getting involved and putting forward some great ideas in the chat. It's really nice to see your questions for our presenters and your involvement in these webinars, so thank you. I'd also like to say a quick thank you to Joan and the Israeli Ergonomics and Human Factors Association for supporting us with developing this webinar and getting involved with this session. So thank you very much to Joan and the Israeli Ergonomics and Human Factors Association there. While I'm here, I'd just like to point out our next webinar, which is on the 16th of November at 4 o'clock. And this event is looking at exoskeletons and exploring the advances in the use of exoskeletons and their development. So if you would like to find out a bit more about exoskeletons, then please sign up for that event on the 16th of November. So finally from me, thank you very much to everybody who's taken part, and we look forward to seeing you at the next one. Thank you.
Thanks a lot.
Thank you very much. Bye-bye.